So thank you everyone for the invite. I think Dr. Naeem killed my presentation before I start. Thank you, Dr. Naeem. There is me between Dr. Naeem. I just want to let everyone know he's a Hilali fan and I'm an avid Ittihadi fan. I always should mention that. And tomorrow is the game, so looking forward to it. So I'm an RF guy. I'm going to talk about the history. So even if you don't want to know, if you're not interested about RF, I think it's good to know about the history, what the progression of RF is. As Dr. Rowan said, it's been decades of technology that we've been using for the last 20 or 30 years. So I have no disclosure. So I'm going to discuss today about the safety and efficacy of RF, and it's mainly going to be related to the power and the duration. In our center, we are 3 people, me and Fahad. The younger EP are using the high power. I don't see Dr. Qabbani. He's our senior guy. He's in a low power. And we continue to debate every case, especially if I don't isolate. I said, I told you, go to the low power. But I'm going to show you the data that high power is really efficient. We're also going to talk about the future of irrigated RF. And what is the perfect combination of power and duration to get pulmonary vein isolation? So our goal when we deliver RF lesion is to get a durable transmural lesion. The current practice varies between centers, but we all in the RF, we use the irrigated catheter with a different recurrence rate. The older data from low power estimate that the PVI is not isolated at a rate of 22% after the procedure. So it all lies behind physics and biophysics. What is high power, what is low power? So when we deliver a lesion by the irrigated catheter, we rely in 2 heating methods. The resistive heating that's delivered by the tip of the catheter. So بالعربي اللي هي الطاقة اللي بتخرج من القسطرة على التشو. And then we have the conductive heating, which happen few seconds after we deliver the initial lesion. So traditionally, we used to use the 25 to 35 watt over 60 seconds, but taking consideration that we've been having a higher rate of reconnection with the low power, high power, short duration seem to be very lucrative option to be used during ablation. And regarding is it effective or not, because we always get, is it effective? It's the low power, we've been using it for 30 years. We have all the data. Why we switched to high power? Where I trained me and Dr. Wael, we were fellows. We were doing this study, the AWARE, where we start to deliver not a single waka, we do double waka instead of a single waka. And we found that with high power, short duration, we have less rate of recurrence of documented AFib. And of course, our goal as electrophysiologists when we do AFib is to spend the least amount of time in the left atrium to decrease the risk of stroke. So of course, when we went to high power, short duration, our procedure time is much, much lower. And you can see that the complication rate risk is almost nil. You see with the high power, short duration is almost 0, and even in the low power, low duration is minimal. This from the study. So the findings showed that high power is effective strategy. There is no signal of increased harm because people said, okay, you're using higher power, your risk of collateral damage is high, but actually is not. And you actually gain less procedural time and less fluoroscopy time. And this not only proved by a single study, we have here a meta-analysis that showed that all studies showed that AF recurrence with high power short duration is significantly lower in the term of AF recurrence, and the procedural time is much shorter. First pass isolation actually is the same between the high power and the low power. And let's go to the safety. So this study, we were just talking about the risk of atrial fistula. So in this study, they had two arms. They did the low power and the high power, and they scoped patient 4 to 6 week post-ablation, and basically they found that there is no difference in the risk of esophageal thermal injury with 0 incident of atrial fistula. What about very high power short duration? So timing, we started, I'll tell you a story. I've now been doing ablation for 7 years. I started with 30 watts, 60 seconds. Now we went to 50 to 40 watts, and now it's currently not available yet in our region, but we have the very high power short duration ablation where you can apply 90 watt for 40 seconds. And actually studies showed that PVI with very high power short duration, there was no difference in recurrence of atrial arrhythmia. And even when you have recurrence of atrial arrhythmia, the rate of pulmonary vein isolation with the very high power short duration was much, much higher in comparison to the control group. So this also comes at a much shorter procedure time and much shorter left atrial dwelling time. Some people are talking that the very high power short duration, you cannot achieve a very well transmural lesion. And here a study was an experimental. I just want to bring this idea where instead of delivering only a single lesion, you will deliver double non-repetitive lesion at the same spot where you give a break between your two lesions. So you give 4 seconds, you give a rest for a few seconds, then you deliver another lesion. This, you get a deeper lesion and less risk of a steam pump. So when you try to do a double repetitive lesion, they found that you can get better lesion depth and better lesion volume because you can get a higher temperature at the tip of the catheter. There's been talks about the incidence and the predictor of stroke with high power, but this study showed basically there is no difference between high power and low power on the incidence of stroke and silent cerebral embolic event. So just to sum up, what is the perfect combination to deliver a lesion? I think this slide sum up all what I want to say. So, and exactly what Dr. Fahad said, you want to have the right setup, anesthesia, you need to monitor your impedance, you need, I personally look sometime on the EGM, you need an appropriate contact force that's monitored whether by ablation index or LCI. You need to have minimum catheter shifting, and your vector direction should be perpendicular toward the tissue, and you try to aim for a good lesion. And this is just to sum up the concept of high power. So this is my last slide. For high power, you get deeper lesion, deep lesion, but not to the extent where you can perforate. While with low power, low duration, with the conductive heating mechanism, you can get way deeper lesion than high power. So, in conclusion, we have no, I think, consensus yet on the power and the duration of RF. There is still rapid evolution, and I honestly and respectfully disagree with Dr. Naeem for two things, that he's number one, he's Hilali, and the second thing that RF will disappear in 5 years. Thank you so much.